Hello, everyone. Thank you for joining us. I'm Susannah Sirkin, and I'm a longtime member of the Safeguarding Health in Conflict Coalition. Very honored to moderate today's webinar. Huge thanks to the University of Manchester. We're so grateful to the Humanitarian and Conflict Response Institute at the university for hosting this together with the institute there, RIAH, R-I-A-H, researching the impact of attacks on healthcare, which is a collaborator with our coalition in documenting and analyzing attacks on healthcare. The Safeguarding Health in Conflict Coalition is a coalition of international NGOs working to protect health workers, services, and infrastructure, and to strengthen the documentation of these attacks and other forms of violence, and to demand accountability. Today, we're presenting and discussing the findings of the 10th annual report of the SHCC, the coalition, presenting the findings, the analysis, and the report is entitled Ignoring Red Lines, Violence Against Healthcare in Conflict. I don't need to tell you that this is an extremely sobering report. It has been 7 years since the United Nations Security Council Resolution 2286 on protecting health in conflict. This resolution was meant to reinforce the long-standing humanitarian norm that health facilities and personnel must be sacrosanct and protected from violence, that they should be safe spaces to deliver and receive medical care. But instead, this year, as we hold this webinar, we have witnessed relentless bombings of hospitals in Ukraine, health facilities invaded and medics killed in Sudan, with hundreds of health workers fleeing the grotesque violence in the country's capital and in cities and villages throughout the land. And we've also seen and documented the continued decimation of the health system in Myanmar, to name just a few examples. The 10th annual report of the Safeguarding Health in Conflict Coalition, issued this very month, documents the number of attacks on health reported for just that 1 year, 2022, at an all-time high of 1,900 incidents. And of course, the true number is surely much greater, as so many incidents in so many places around the world go unreported. So what are we talking about? We're talking about the bombing and shelling of hospitals and health facilities, threats, arrests, kidnapping, disappearances, and the killing of doctors, nurses, and other healthcare workers. We're talking about incursions into facilities with armed forces and military-style weapons, and interference with care in so many locations. We're talking about the looting and pillaging of medical equipment and supplies, and the obstruction of access to care, sometimes in long-time chronic situations. And all of these violations are occurring with utter impunity. And we're at a crossroads internationally on this issue. There is still virtually no accountability for these unceasing violations of humanitarian law. And it appears that states have not lived up to their commitments agreed upon time and time again. And particularly 7 years ago, when the violence against healthcare in Syria, Yemen, and elsewhere prompted international reassertion of the protection, prevention, and accountability for these crimes and this violence. Now, a vast number of these attacks are war crimes, and in some cases, they rise to the level of crimes against humanity. And of course, they are gross human rights violations, tearing apart these longstanding norms that delivery of healthcare in times of armed conflict is to be protected. And it's reinforced by so many UN resolutions, and they have devastating impacts on health. So it is a humanitarian crisis, it's a human rights crisis, it's a health crisis, and one we must all understand and confront. So I'm very pleased that we have such an informed panel of presenters today, offering both an overview of the findings and the data on these violent attacks, And today, we're also fortunate to have 4 excellent witnesses and reporters from the very zones of conflict that the report discusses. And then towards the end, we will have Leonard Rubinstein, who will give us some ideas about what needs to be done to stop these crimes and to hold perpetrators accountable. I'm going to introduce each speaker before they present, and we'll make sure to leave some time at the end for questions from all of you. Please post your questions in the Q&A, and we'll try to respond in the time that we have towards the end of the hour. We'll be recording this session for internal purposes. Participants present, all of you on the Zoom, will not be recorded. We'll probably turn the recording off during the Q&A. And anything that will be released afterwards will be done only with the approval of today's speakers. As you can imagine, a number of them are in sensitive situations. I'm delighted to introduce and welcome our first speaker, Christina Wille, who's the director of Insecurity Insight and the Aid in Danger Project. Insecurity Insight is a key partner and member of the Safeguarding Health in Conflict Coalition. She will give us an overview of the findings of the 2022 report on attacks on health and conflict. Christina, over to you.
Thank you, Susannah, and thank you for everyone who's here today. So I'll try to share my screen. Okay, so thank you very much, everyone, for being here. And it is my honor to talk about the key trends that we witnessed in 2022. And in past years, when I talked about this, I always felt it really important to stress that I wasn't very sure that the increasing number of events that were documented year on year did not perhaps reflect our common concern in better documenting such incidents. But this year, where we've recorded close to 2,000 events, I'm at pains to say that for the first time, I actually believe that this really reflects an increase in the numbers compared to the previous year by a staggering 45% in terms of what we've been able to document. But there is now no doubt in my mind that the year 2022 was an exceptionally brutal year for healthcare. And while these numbers are shocking on their own, I would like to start by talking about one particular health worker, a nurse from Myanmar who was 27, Tsa Nang, when she was killed last year, pretty much exactly a year ago. She had not finished her education. It was interrupted by COVID and then the coup in the country. And she had moved to a village that was held by the People's Defense Forces, groups of soldiers that opposed the junta government. And this small community of some 2,000 people did have no access to healthcare because they would have had to cross that bridge you see on this picture here to reach the next closest town. So the young nurse was living with this community. At some point, the soldiers of the People's Defense Forces tried to take the bridge back. As a revenge, the security forces entered the village. The community fled into the forest. The soldiers laid mines to slow down their advances. One of the soldiers was injured. Tsa Nang stayed with the soldier to look after the injuries, and she was captured. And later, she and 4 others were found dead, executed by the security forces. They were the local community leaders, the soldier and a teacher, and the health worker. And I'm sharing this example with you because for me, it illustrates so many things. On the one hand, it is the one story of the 230 health workers killed last year. It is also the story of a young health worker who worked outside the formal aid system. Far too many health workers working for NGOs were killed. Far too many were killed who worked for local partners of the international aid system. But it is absolutely shocking the extent to which this violence affects people who work for the ministries of health or in other structures that are not directly supported by the formal health system. And that to me is one of the biggest crises we're looking at in this case here. But the killing of health workers is not the only thing we have to be concerned about. The number of kidnappings has also risen in 2022 compared to the previous year. And here are some of the countries, and we can see that it is in particular in countries around the Sahel in Africa, where we've seen shocking number of kidnappings affecting health workers, their families, their colleagues, and health services. And then there is the issue of arrests of health workers. And this is always in particular difficult to document. And in 2022, we can see here, first of all, how it's overall been increasing over the past years. But in the last year, it is again Myanmar where we've seen the documentation of over so many arrests, and we don't know how many of those arrested in the previous year have ever been released. And it's also Iran that came to our attention last year as the number of health workers arrested, and it continued in Sudan and many other countries. And this is another phenomenon that we have noticed year on year. When there's political violence and these are suppressed by the powers, it is very often the health workers who look after the injured demonstrators who are then arrested, tortured, and otherwise badly treated in prison. And this is something that we need to be very mindful of. It happens again and again. Every year it is in new countries. And then in the year 2022, it was also the destruction of the health facilities. In Ukraine, we documented over 400 individual incidents. And for these, we do have the coordinates, we have the names of the hospitals, or we have very detailed information from a trusted partner. The scale of the destruction of health buildings in Ukraine is on an unimaginable scale to the extent it has been documented. And as you can sort of see here from this graph, which goes into this year, it is something that continues month on month. It was particularly intense in the early weeks of the invasion, but it continues, and it continues today. And here I've also sharing with you a graph that just shows the extent of reported incidents on destruction of health facilities. And you will notice Ethiopia in the first line. And if you have a look at the report, you will see that this graph is not included in there because this shocking high number of Ethiopia is derived from a different methodology as we usually use. Usually we really document each incident. For Ethiopia, these are a cumulative number we've received from other partners, and we haven't independently verified each incident. But I'm sharing this in this presentation because it highlights another concern. Ethiopia this year has not been given its own chapter because the number of newly reported events has declined due to the ceasefire. However, the impact on the health system continues, and that is one of the biggest concerns we need to think about, of how long it actually takes to repair the damage from this destruction to the health system. One other thing I'd like to draw your attention to this report for this year that is new is that for the first time we systematically highlighted whenever we noted an attack on a vaccination campaign, and these are scattered throughout the report, in total 28 of such incidents, and they also have big impact on long-term public health. And finally, there is the issue of obstruction to healthcare. It is a very important issue, but incredibly difficult to document. And it is really mainly from the West Bank and Gaza, where such incidents are one by one documented, and we have some idea of the scale of it, and we will hear a little bit later about this. But the main reason, as I've already alluded to, is really of doing this report is understanding what the impact is on delivering healthcare. It is the cost of the reconstruction. It is the cost of running healthcare services in insecure places. And it is the cost for individuals who need healthcare, who have to travel longer and longer distances to reach healthcare that has such a devastating impact on access to healthcare. And we're also getting increasingly evidence from various studies across the world that it is in particular maternity care and chronic illnesses that are particularly affected by this violence against the health system. And then they're the health workers themselves. And in 2022, we had various surveys in different contexts done, and they all showed very similar results. Health workers experience extreme levels of stress from these attacks on the healthcare system. In particular, when these attacks are repeated, there is a sense of hopelessness that it becomes very difficult for some health workers to work. And the psychological impact can get so much that health workers have to give up the profession they love, or at least have to take time off, because the toll on them is becoming unbearable. And that on its own has a huge impact on access to healthcare. So here are some of the recommendations that Len will also sort of allude to a little bit more. We believe there is a real need to address the impunity of these attacks, to strengthen the prevention around it, and most of all, to strengthen the global and the domestic leadership. And for that, I'm very grateful for all of you who are here today to discuss this issue and to see what collectively we can do. And with this, I will stop my overview, and I look forward to the contributions from our panelists who will illustrate some of these country situations further. Thank you.
Thank you so much, Christina. Indeed, grim and sobering, but also a testament to the incredible efforts of so many people to gather this really vital documentation. I'm very pleased to introduce our next speaker, Halla Keir, from the London-based advocacy organization, Medical Aid for Palestinians, MAP. She'll speak about another form of assault on healthcare, the chronic obstruction of access in the occupied Palestinian territories. Welcome, Halla.
Thank you, Susannah, and thank you to everybody that's spoken so far with some really horrific stories. Doesn't sound too dissimilar from the area that we work on, but it is, of course, a depressing outlook. I'm here from Medical Aid for Palestinians. We're a UK charity, health and humanitarian charity, and we work with local Palestinian organisations towards a future where all Palestinians can access an effective, sustainable and locally led system of healthcare. Our work includes direct emergency response, as well as capacity building and working with local community organisations. So, for example, we work with the Palestine Red Crescent Society, the kind of primary emergency response team in the occupied Palestinian territory, providing them essential items to be able to carry out their duties, as well as support and guidance on their advocacy and documentation of violations. So just to give a bit of a background of the context in which we work, the health needs that we respond to in the occupied Palestinian territory arise from Palestinians' daily lived political reality, and that's a reality of ongoing occupation, blockade on Gaza, forced exile, systematic discrimination, fragmentation. And fundamentally, all of these prevent Palestinians from enjoying their rights to health and dignity by preventing essential access to the building blocks of health, including livelihoods, freedom of movement, water, food and shelter, as well as preventing the sustainable development of healthcare systems. Now, we're here to talk today about attacks on healthcare, and so I'm going to specifically talk about how these policies and practices have profound impacts on the ability of Palestinian health workers to be able to carry out their duties. For example, I mentioned restrictions on freedom of movement. In 2020, the UN recorded 593 obstacles to Palestinians' movement in the West Bank, which includes permanent checkpoints, earth mounds, flying, so moving checkpoints, and the separation wall around East Jerusalem. Just to give a quick example of what those movement restrictions mean for health workers, for example, ambulances that need to enter East Jerusalem, which is where the 6 specialist hospitals are across the occupied Palestinian territory, those are in East Jerusalem. Palestinians that need to access those hospitals, Palestinian ambulances that need to access those hospitals, they must go through a checkpoint. And when they get to the checkpoint, they must remove the patient from the Palestinian registered ambulance and transfer them into an Israeli registered ambulance to be able to travel into East Jerusalem proper. And that process causes delays, as well as significant discomfort and medical risk for the patient as they're delayed from accessing healthcare. It also violates the sense of privacy that they may want to have as an injured person as they're being carried between ambulances in full view of everybody else at the checkpoint. Data provided by the Red Crescent Society, as I mentioned, one of our partners, shows that between 2019 and 2021, 93% of their ambulances were delayed due to the back-to-back process, that process of transferring a patient from one ambulance to another. So that's just a bit of explanation on the kind of context in which we work. To focus in on the situation today, I'm going to speak particularly about the West Bank, as Suzanne mentioned, on the ongoing and systematic obstruction of Palestinian health workers. Today, we see escalating Israeli military and settler violence against Palestinian civilians and healthcare workers, and that's causing a significant rise in injuries and emergency health needs in the occupied West Bank. As of the 2nd of June, more than 140 Palestinians have been killed, according to the UN, and more than 4,500 have been injured. At the same time, hospitals and first responders are struggling to respond to that influx of injuries and casualties amid dwindling resources and the restrictions on freedom of movement. The Safeguarding Health report for 2022 identified 171 incidents of violence or obstruction against healthcare across the occupied Palestinian territory last year. That includes violence against paramedics, as well as damage and obstruction to ambulances. It's worth noting, I think, as Christina had earlier, that this isn't a comprehensive report on every single obstruction that happens, because some of these are such daily and regular occurrences, it's not always reported. The Palestinian Red Crescent Society, for example, documented more than 900 violations against their teams in 2022, because they include the process of obstruction through the back-to-back process, which isn't often included in World Health Organization figures. This trend that we're seeing of escalating military and settler violence is continuing into 2023, with persistent reports that Palestinians have died during military raids on Palestinian cities and settler attacks. And this especially seems to be the case where Israeli forces are preventing or delaying access for paramedic teams. The now routine obstruction of Palestinian healthcare workers includes the comprehensive temporary closures of entire cities. We've seen this take place in Nablus, we've seen it take place in Jericho and other Palestinian cities across the West Bank, which has prevented or delayed Palestinian ambulances from reaching casualties and patients from reaching healthcare facilities. Earlier this year, during a raid on the Jenin refugee camp, restrictions on entry into the camp meant that PRCS ambulances were forced to wait more than an hour before being able to access critically injured people inside. The head of the emergency and ambulance department at PRCS told us that Israeli forces allowed our medical teams in only after they made sure that many of the injured had lost their lives. It's not the first time, nor is it the last time, that Israeli forces will impede the access of medical teams and wait until the injured bleed to death. As is said in that quote, this is not the first time and it's not the last time, and it seems to be becoming more of a repetitive occurrence that ambulance teams are restricted from accessing injured people until they've bled out. In another case, during another military raid on Nablus in February, a PRCS ambulance was also denied access to reach a 2-year-old girl who had heart problems and was suffering from tear gas inhalation. The paramedics were forced to rush to the child's home on foot instead of in the ambulance, and on the way, they were shot at with rubber-coated steel bullets and then forced to remain in the house for 40 minutes until it was safe for them to evacuate the child. These restrictions are not standalone. It's unfortunately becoming a pretty systematic and repeated pattern. And the ones that I've just mentioned in 2023 are reminiscent of the one that is documented in the Safeguarding Health report, where we saw a 3-week closure on Nablus imposed by Israeli forces, which had a critical impact on access to healthcare for chronically ill patients, as well as pregnant women, and also on the impacts to be able to access supplies that are stored in Nablus's central healthcare warehouse. Alongside the constant obstruction, repeated obstruction of Palestinian health workers, they're also facing direct instances of attack and violence from Israeli forces or settlers. So on the 30th of March, during a military raid on the city of Tulkarem, Israeli forces instructed PRCS medics to enter the EMS station and stay there. They weren't allowed to leave. The soldiers then mounted a weapon to the front of their ambulance, damaging the windscreen, and used the ambulance as cover while they fired from behind. So we've mentioned Israeli forces, as does any occupying power, has an obligation not to use medical transports or personnel to shield combatants. And that's a violation of international law that it's done so. All of these attacks, as well as the systematic discrimination and fragmentary policies that Palestinians face across the occupied West Bank and Gaza, presents an ultimately discriminatory situation under which Palestinian civilians and healthcare workers are under repeated attack, while illegal Israeli settlers have unimpeded access to services. And the extent of this discriminatory situation can be measured in the severe health inequalities between Palestinians and Israelis. In 2019, there are almost 3 times as many doctors per 1,000 people in Israel compared to the occupied Palestinian territory. The fragmentation, including those access restrictions that I mentioned, has contributed to a shortage of specialists in some areas of the OPT, such as family practice, oncology, neurology, pediatric surgery, and psychiatry. This ultimately has an impact on the health outcomes for Palestinians as well. We see that life expectancy for Palestinians in the OPT is 9 years less than it is for Israelis. Child mortality and neonatal mortality rates are more than 5 times higher in the OPT than in Israel. Now, again, this is not purely down to the attacks on healthcare that I've outlined and the obstruction of healthcare, but the entire system of systematic discrimination and fragmentation and the policies that are imposed upon Palestinians. The last thing I'll say, and I think it's been outlined fairly clearly so far, is that the situation in the OPT today is fueled by persistent impunity for pervasive violations of international law. MAP first started reporting on this in an official capacity in 2015, where we saw the health sector in Gaza under attack. We reported on those cases again in 2020, for which there'd been no accountability. And we've continued to report on these attacks and demonstrate how warnings over this systematic impunity have gone unheeded by the international community. And that impunity has had foreseeable deadly consequences that are borne out today in both the West Bank, Gaza, and in East Jerusalem. So I just want to reiterate the calls that are made in the Safeguarding Health and Conflict Coalition report, but it is fundamentally a critical part of doing this work. It's a fundamental part of prevention of attacks on healthcare, to pursue accountability. And that's why we call on all governments to support genuine investigations into and legal accountability for serious violations, including attacks on healthcare workers and healthcare facilities. And with that, I'll pass back over to Susannah.
Thank you so much, Halla, for especially highlighting this longstanding and chronic situation for years. The OPT accounts for a very high number of individual incidents, and as you described, this chronic situation and the ultimate health consequences. It's really powerful. I'm going to let everyone know, and I do apologize both to speakers and our audience, but hope that you'll be able to stick around a little longer. We are going to go to 15 minutes after the hour. Apologize that we didn't really plan for the length and depth of these very critical presentations, and please do stay on. I'm thankful for University of Manchester that you're able to keep this open, and welcome you all to stay for the Q&A. And I also want to note that if you have questions, please put them in the Q&A. I don't see any yet, and we will leave some time for that. Without further ado, the last of the 4 individual country presentations, but certainly not the least, Lyubov Smachylo from Ukraine, who's an analyst at the Media Initiative for Human Rights, documenting and investigating international crimes committed in connection with the Russian aggression in Ukraine. And she will discuss accountability efforts that all of our speakers have so powerfully talked about. Over to you, Lyubov, and thank you so much for being with us as well.
Thank you. Thank you very much for this possibility to talk about Ukraine. So I will briefly present the situation on medical personnel, both civilians and combat medics, and also on accountability question. So the information we have about the violation of human rights during this full-scale Russian aggression in Ukraine is mainly from the testimonies of victims during our documentation processes. And we have many testimonies from civil doctors who are civilians and who were forced to stay and work under Russian occupation. And these doctors told us about the Russian army making pressure on them to commit crimes such as sharing all patient personal data. These doctors were not allowed to move to the territories that were under Ukrainian control. And we have a lot of story about ambulances which were shelling on their way to the patient, and it was clearly a target of Russian army. And also we know medics, doctors and medical personnel who were in captivity of Russian army, and they couldn't leave a hospital, and they couldn't evacuate patients from there, and they were under permanent shelling with no windows in the winter time, and they should give all this medical aid and do surgeries in this condition without medication. And we dispose a lot of information from the combat medics. And normally they are also protected by the international humanitarian law, but Russia violates the international humanitarian law. And we have a number of problems with the status of combat medics. And the biggest is that on the battlefield, they cannot, they become a target of Russian army, and they cannot have and put any distinguished symbols or patches or signs, because if not, they become first to be shelled, and this is very dangerous for combat medics. And the second problem is once they become a POW, prisoners of war, they are treated with violence as any other POW, Ukrainian POW, and so they are beaten, tortured, and they are not exchanged at the first time. They are not on the top of the list of exchanges as it should be. And we have documented testimonies of a doctor imprisoned in Olenivka colony, a very famous colony where Russians tortured Ukrainian POW and even made a terror in there, killing 40 prisoners of war. And there were 130 injured prisoners of war, Ukrainian prisoners of war, and only 2 doctors who were themselves prisoners of war, who were there to treat these people, these prisoners of war, and they had no medication and very bad condition to do this. And for our organization, it is important the documentation processes, investigation, but also our main goal is accountability of for these war crimes committed during the Russian aggression in Ukraine. And one of our work lines is trial monitoring, and we show all important court decisions on war crimes committed in Ukraine. And for example, we have a recent court decision. 2 Russians were sentenced for the shelling of a medical facility in Trostinets, north of Ukraine. So Russian tanks shelled Trostinets City Hospital in March of 2022 during the city's occupation. And the hospital suffered significant damage, and the tank men who could have been involved in the shelling of this medical facility have been established by the law and forces, and we know their names. It was a tank commander and the gunner. And on May 9th, 2023, Trostinets District Court, Ukrainian court, sentenced them to 11 years of imprisonment. So their actions are qualified under Criminal Code of Ukraine. It's violation of the law and customs of war committed with a prior concert. And of course, this trial took place in absentia, but the accused are wanted. The procedure of trial in absentia is where the accused person is not present, but still we can judge them we should of course guarantee all human rights. This person has a lawyer, but still we in Ukraine, under our Ukrainian criminal code, we can have this in absentia judgment. And of course, for us, for Ukrainians, we want this aggression to stop. But for us, it's crucial that we can held responsible for those involved in these crimes.
Thank you so much, Lyubov, and thank you for focusing on the accountability issue, which I'll move to immediately to Len Rubinstein. Thank you to all of you who are sticking around just for a little longer, because the most important question after hearing these really horrific accounts, as well as learning about the important efforts of so many people in so many places, is indeed, what should we do about this and what can be done? And for that, I turn it to Leonard Rubinstein, who is the founder and chair of the Safeguarding Health and Conflict Coalition, professor of the practice at Johns Hopkins School of Public Health, and author of the very important book, Perilous Medicine. And Len is a leading expert globally on this issue. Len, thank you.
Thank you, Susannah, and thanks to all the very compelling speakers from 4 countries. It shows how pervasive this problem of violence against healthcare is. In the past decade, there has been much more much greater attention to this problem, and it's been the subject of resolutions at the Security Council at the World Health Organization. And there's been a great deal of rhetoric that violence is unacceptable, but there's been only modest action to prevent healthcare from attack and hold perpetrators to account. The gaps are enormous, even though some modest steps have been taken. First, as everyone has mentioned, there needs to be accountability. 25 years after the establishment of the International Criminal Court, we're still waiting for the first significant international prosecution on attacks on healthcare in conflict. And what does that mean? Russia faced no consequences for targeting hospitals in Syria, so it does it again. Myanmar faced no consequences for attacks on healthcare workers in the late 20th and early part of this century, and is doing it again. Other combatants watch and see that they can do it too without consequences. Now, there's some encouraging signs, not only through domestic prosecutions in Ukraine, but the ICC will address war crimes in Ukraine. But we must press for these prosecutions both there and elsewhere. And the problem of accountability is not restricted to lack of prosecution. Even the mildest forms of accountability, such as naming names, is continually thwarted at the UN. States like Saudi Arabia have lobbied and even used threats to keep its name off the list of persistent perpetrators of grave violations against children. We have to stop this. There has to be a level of political commitment that ends this manipulation. Second, there needs to be more aggressive work to strengthen prevention. Domestic laws continue to permit attacks or arrests of health workers under the guise of counterterrorism. And despite rhetoric, states have not followed through on simple steps like adjusting their own military doctrine, practice, and training on issues like hospital searches, checkpoint operations, ambulance passage, other dimension of combat operation. These are simple, but they have not been done. Third, while we're proud of the coalition's increasingly sophisticated method of gathering and reporting data on attacks, as reflected in this report, it's not the job of NGOs and academic centers to undertake this task. It's an international obligation which was recognized more than a decade ago by a resolution of the World Health Assembly. It established a process for WHO to collect and disseminate this data. But it's well known now that that process is flawed and has limitations identified by NGOs, by member states, and last year by an important report by the International Peace Institute. The sources of data it uses are too limited. Collaboration with civil society is close to non-existent. Its list of events omits even location of attacks, what happened, and if known, who did it. Just to give you an example, the coalition reported 50% more incidents of violence in 2022 as WHO did, at 600 missing events. In Myanmar, we reported more than 5 times as many incidents as did WHO. The reasons are the inadequate and rigid methods for data collection, exacerbated by the insularity of WHO and unwilling to reach out to civil society, and a refusal to review its own methods. In fact, after reporting 0 attacks in the Tigray conflict, it has now removed Ethiopia from its dashboard. It's up to member states dedicated to appropriate data collection to insist on reform. Finally, there's a need for leadership on every front. Donors need to allocate funds to address the enormous psychosocial stresses that we've heard about today. Ministries of health need to engage with security forces to protect healthcare, including their own health security forces, and lead on security and mitigation strategies. The broader health community has to engage beyond the few associations like the International Council of Nurses and the World Medical Association that regularly speak out. Regional approaches are necessary. There are opportunities to take the steps, but it's really time to get serious about protection and accountability. Thanks.
Thank you, Len. And if all of our speakers would turn on their cameras, we will open to any questions. And clearly there is a lot to do. And thank you, Len, for calling out all the specific actions. So thank you, merci beaucoup à tout le monde. Everyone who participated, sorry that we went over, but I think this final piece has been critical. Please wait for the email that you'll be getting, which will give you links to a number of the reports and discussions that we talked about today. And thanks very much to all of our participants, especially those who reported really things that are deeply personally traumatic as well as traumatizing to your countries and communities. We hope that next year we won't see an increase in the numbers, but we'll start to see the trajectory going in the other direction. Thank you all.